Greetings from Expert Perspectives on Lymphoma Myeloma 2015 here at the Waldorf Astoria in New York City. This is our first day of the meeting, of a three-day meeting, and our first day is devoted to multiple myeloma. I am Dr. Morton Coleman, Director of the Center for Lymphoma and Myeloma at Weill Medical College and the New York Presbyterian Hospital. I have with me here today Dr. Ruben Niesvizky, who chaired our first session on multiple myeloma. Dr. Niesvizky is the chair of our myeloma section at Weill Cornell Medical College. Dr. Niesvizky, welcome. Tell me, what was the most exciting paper amongst the many exciting papers that we had at the conference from your perspective?
Well, it's very, very difficult to identify one single one. I would rather tell you about the sections on basic science and translational research, followed by the most exciting clinical data that we saw. So from the perspective of basic science and translational science, it was very exciting to be able to see the advancement of identifying new biomarkers and probably identifying mechanisms of action as how immunomodulatory drugs work. Also, new biomarkers in trying to define immunosuppression and probably alternative ways of following burden of disease.
I think most of our viewers are clinicians, and they might be very much interested in finding out from what you heard today at the conference, how would you treat a patient not on study who is transplant eligible, who comes in for treatment? What would be your choice, and would you transplant early? Would you transplant late?
I think the principles for transplant eligible or non-transplant eligible are getting blurry, and I think that most of the experts, as was underscored in our meeting, is that we require a profound induction. We need a achievement of a CR, deeper than a CR probably by molecular or flow cytometric techniques, and probably even with imaging techniques. Everybody agrees that either in the transplant eligible or the transplant ineligible, the goal of the induction therapy is to achieve a maximum response as possible, albeit with more drugs, with sequential drugs, or with a continuous therapy approach. Either way, any program will be more successful the deeper is the responses.
In light of what you heard, do you think we should look at treatment in three segments, induction, consolidation, and maintenance? Could you address each one of those? How would you first induce these patients for a profound remission?
So for induction, it appears that the most successful program combines corticosteroids with proteasome inhibitors and immunomodulators. And if you put the best available combination, appears that carfilzomib, dexamethasone, and lenalidomide, it is a combination that gives the deepest responses and at the lesser price of toxicity, followed by on the elderly or the infirm, requires perhaps a lesser intensive therapy, dose modifications, but again appears that three drugs appear the most efficacious.
From what we heard, is there any benefit in adding that fourth drug to the combo?
Traditionally, a fourth drug was going to be deleterious given the increased toxicity and therefore the inability to provide proper dose intensity in the most effective drugs. So from the evolution study, we learned that the addition of alkylators to immunomodulators does not appear to benefit and just preclude proper dose intensity. And therefore, we will see in the future the addition of additional drugs that per se can have single agent activity. And I can foresee perhaps the addition to the triplets, the use of monoclonal antibodies.
So maybe one day we will have 4 drugs, but that 4th drug will be a monoclonal antibody that won't add to the toxicity such that you can't get in the proteasome inhibitor and IMiD, which are our most effective drugs. How would you generally consolidate based on what we heard?
So following induction, I think everybody agree that stem cell collection, cryopreservation should be pursued. And I think that's a general rule for most of the patients, perhaps not the very elderly, but outside of that, there is sufficient data that even stem cell consolidation can be considered even in the elderly, which are fit. And therefore, the consolidation, which is typical for the youngest patient, would be autologous stem cell transplant with high-dose melphalan. And hopefully in the future we can improve upon that, like what we're doing in our center, trying to combine with alternative agents such as second alkylator or proteasome inhibition or immunomodulating, also for the conditioning regimen for the stem cell transplant.
One of the issues, of course, is should you transplant early or transplant late? In other words, can you harvest the patient and wait till they either relapse or become refractory, and preferably relapse, of course, and then do the transplant? Do you think the data are compelling for doing it up front at this point, or you think we just simply don't know which way to go, early or late?
A lot has to depend on the MRD state. And I think in the future, if we can achieve a robust minimal residual disease negative state, regardless of what's the therapy, then transplant can be deferred. However, the great majority of the patients that we see now fail to reach that MRD negative state, and therefore consolidation with stem cell transplant is still a way to go. We are anxiously waiting for the results that are going to be presented in ASH, in which at least 2 clinical trials are looking at, one, the question of deferred transplant, and the second question is whether a second transplant is superior to maintenance post-transplant.
Now, with regard to maintenance, we heard a wonderful debate over whether one should use a proteasome inhibitor for maintenance, whether one should use an IMiD for maintenance, or one should just not use any maintenance at all. I left the conference at that point not sure what to do. What is your opinion on maintenance? Should we maintain? Does it add to the survival of the patient? We know it increases the duration of remission or response, as the case may be. But do you think that we could perhaps not maintain the patient and wait for relapse to occur? What would be, and then be able to use those drugs? How do you approach your patients with regard to maintenance?
At this point, I think the most solid data comes from maintenance that supports improvement of progression-free survival. It is controversial whether improved survival is yet achieved because of flaws in the design of trials, because of availability or lack thereof in the salvage setting for novel agents. So we still have to learn better what's the best patient to maintain. In general, our approach is to achieve the maximum response possible and maintain therapy. That does not necessarily mean the program of transplant followed by maintenance, but if you can achieve a maximum response with agents A and B, maintain those type of therapy. And even in the expert who voted against doing maintenance, he was adamant that the induction should be as long-lasting as possible to achieve that maximum response, and that's what we have always called continuous therapy.
Well, let's say you achieve an MRD negativity using the most sensitive techniques we have available to us now. Do you think there's any merit in maintaining those patients?
I still don't know the answer, and I'm waiting for the proper clinical trials. We still maintain those patients.
And we also had a very interesting debate on the use of HDAC inhibitors, whether they actually added anything to our armamentarium in the treatment of multiple myeloma. What is your opinion on the use of HDAC inhibitors? Do you think they add value?
There is a core set of medications which have all proven to have single agent activity, and those are the proteasome inhibitors, the immunomodulators, the corticosteroids, and the alkylators. I think the major core medications, those are the ones that stay. The use of monoclonal antibodies, perhaps CD38 antibodies, will be added to that core. Then we have another set of adjuvant medications that can enhance or help increase the effect of this core. Yes, HDAC inhibitors can fall in that category. The problem of the current HDACs is the toxicity and the inability to give a long term. I was very excited to see that the addition of panovinostat can increase significantly the complete response. So I can foresee using HDAC inhibitors in induction rather than in continuous therapy, and therefore avoid the toxicity, increase the response rate, particularly in high-risk patients, and then use alternative agents for maintenance.
It'd be nice if we have some HDAC inhibitors with a little less toxicity, and I know they're in the pipeline.
Correct.
Now let's talk a little bit about the hottest, newest subject in myeloma, therapy that is, and that is the monoclonal antibodies. We have a number of them. There are probably two that will enter the market very shortly, Daratuzumab and Elotuzumab. Would you tell us what the merits and demerits of each one of them are from your perspective?
Well, let's start with the Elotuzumab, which actually is an antibody which directs against SLAMF7, which has a dual effect, one in the opsonization of myeloma cells, where at the same time activation of NK cells, and appears to be additive to any immunomodulator. So it is very exciting that patients with lenalidomide and dexamethasone have an increased response rate and increased progression-free survival when elotuzumab is added at very little price of toxicity. It's so well tolerated that patients age 80 and 90 are receiving currently in my clinic without any major onwards effect. So this is one of the very rare exceptions in which I favor the drugs without single agent activity, as is elotuzumab, because it has shown that it's so effective and so well tolerated.
Yes, but it is interesting that it has very little, if any, single agent activity. And that's in contrast to Daratuzumab. Tell us your opinion on Daratuzumab as you have used it in the clinic.
So Daratuzumab is very exciting because it has shown staggering activity in people who are quadruple resistant and durable responses. The price is a little more difficult infusion, but with the current guidelines of management of the infusion can be readily be administered without major untoward side effects. There are some nuances on its treatment on how to evaluate complete responses, because all these antibodies are GG-kappa, so you will never achieve an immunofix negative complete remission. And the other nuances is that these people become CUMS positive, and therefore it's difficult to type and cross. And it's, after all, an anti-CD38 antibody, so we're concerned about long-term effects in hematopoiesis because it's a very global antigen. Being as it may, none of these problems have aroused, and responses have been very gratifying.
Yes. Have you seen any autoimmune hemolytic anemias with the Daratuzumab?
No, I have not.
So let's talk a little bit about clonal selection in plasma cell myeloma. Do you think that the use of maintenance in some way or another will clonally select a resistant clone and make it more difficult should the patient relapse? What is your opinion on that?
The subclone development does not necessarily obey therapy, but obeys the genomic instability of these cells. And therefore, you can achieve good responses, and by holding therapy, you will allow clonal evolution. In the other hand, if you can achieve deep responses and keep a suppressive therapy thereafter, you will impede the development of clonal evolution at certainty. So the Darwinian effect on the clonal evolution is more dependent on the variety of the clones available rather than the effect of the drugs given.
Now, you had mentioned that at least what has been shown in the clinic thus far is that carfilzomib and lenalidomide and dexamethasone is our most potent inducer of response and or remission. Do you think pomalidomide, I know there are no data with pomalidomide up front, do you think there's a role for pomalidomide in place of lenalidomide in the upfront setting? Many of us think that maybe pomalidomide might even be a little bit more effective than lenalidomide. What is your opinion?
Well, absolutely, I agree. The best combination in terms of responses for the double refractory appears to be the KPD, which is the carfilzomib, pomalidomide, and dexamethasone. So that's actually a combination that I go often in the very aggressive patients. Think about it, pomalidomide covering patients who have deletion 17 and carfilzomib covering the 414. So those markers that identify poor prognosis can be combined and give outstanding results. The problem is that pomalidomide is not available for frontline, and we'll have to wait a decade for that to happen. So I'm eagerly waiting for new immunomodulatory drugs that appear to be more potent than pomalidomide and be able to be used frontline.
And one last question, where do you see the role of checkpoint inhibitors in myeloma? So far, the data have been somewhat disappointing. Do you think we're looking at the wrong checkpoint inhibitor, or how do you think we should employ checkpoint inhibitors?
Well, we don't know how to employ them. I think we have to learn much more. PD-L1, PD-1 type of assays have to be completed, have to be identified, and hopefully better designed trials can inform us more about that. Certainly, many immune approaches are coming through, including checkpoint inhibitors. We'll have to talk about the dual molecules, and we have to talk about CAR T cells to help in the treatment of multiple myeloma.
One interesting and intriguing aspect of it all, and again it's just a nuance of report, is the use of ibrutinib in myeloma. Have you used it, or do you think there may be a role for one of the signaling inhibitors in myeloma? The report showed that the doses that they were using were extraordinarily high, in my understanding, in order to get a response. But my understanding is that you can use much lower doses to fully saturate the BTK, Bruton's tyrosine kinase. What is your opinion on ibrutinib? Do you think it might have a role for us after all in the myeloma, or should we just remain with the lymph malignancies?
Well, again, it is early. The drug is being tested in several contexts. Ibrutinib in combination with immunomodulators, ibrutinib in combination with proteasome inhibitors, and we have participated in these trials. Ibrutinib appears to fall in the same category as the HDAC inhibitors, not as a core medication for myeloma, but maybe an additive.
As a supplement.
Now there are other BTKs and agents that are coming through the market. We are participating in those clinical trials, so we hope that maybe even better drugs can have the effect, both anti-myeloma and anti-stroma, because these inhibitors appear to reduce osteoclastic activation, which is such a problem for patients with myeloma.
Well, thank you very much, Dr. Niesvizky. I'm Dr. Morton Coleman, wishing you a good day.